Hi, good morning, everyone. Good to be back. Colonoscopy this morning, and I'm going to start with training, which is very dear to my heart. And the truth is, tomorrow's endoscopist is probably your colonoscopist. Therefore, you need to train very effectively. My other co-fellow speakers are going to be talking about the intubation and extubation phase of colonoscopy training. So I'm going to focus on the other stuff. To understand what other factors make training difficult. We jump through a lot of hoops in our lives, and I think the picture, your trainee trying to get to the secant because that's what they think they need to be doing, is probably will resonate with many of you out there. And there are lots of other things other than the technical issues which make life difficult. So the first one I would talk about would be workplace culture. So if you think about training in your own workforce, what from the list of words on the right-hand side would you say applies to your unit? Is it promoted? Is it embraced? Is it just tolerated? Sometimes challenged, resented, or actively dissuaded? And I suspect at times it will flux and wane, but you really, for training to be effective, everyone has to buy into a training culture, and it really needs to be promoted within your unit. Very difficult to work in a place where the shoulders sag every time a trainee walks into the room. I think the environment is also critical. We have worked very hard in our own unit over many years to try and get all the pieces of kit which makes training more effective. So you need the technology. I think we've got a whole session on this, but scope tracking technology has advanced, and it will enable you to really describe very precisely what's happening with the instrument whilst you're doing the procedure. And I think without this information, it's very difficult to get the trainees to progress in a timely fashion, really. They need to understand the concepts of what they're doing, and I'm sure this will be touched on the subsequent lectures. So I think if you're not routinely using some form of scope tracking device, you're really missing a trick in how to provide a fantastic training environment. Other pieces of equipment which are really useful, simple things like a water pump. And it saddens me a little bit that my trainees will leave my unit and actually go to training in other units. That's normal in the UK. They have got some mandatory training things to do. One of my trainees came back, and we taught them to use a water pump and do underwater intubation. They came back and told they weren't allowed to use it. So the culture hasn't really moved, and everyone isn't necessarily on the same page. But I would encourage you to try and teach the most modern techniques. And the reason for that is it's usually the best one, and it's the simplest one and the safest one. So to enable that to happen, you need the equipment to go with it. So as I say, scope tracking, water pump allows you to get good views apart from anything else. And then more generally in the environment, we talk about something called cognitive load. And that's really the other stuff going around that distract you from what you're doing. And it's sometimes very difficult as an independent endoscopist to remember quite how difficult it was to handle the instrument and move the instrument and get the instrument to do what it's supposed to do if there's lots of other stuff going on in the room. So, having a bleep-free time or a time away where you're not being distracted, and maybe turn the music down and stop the interruptions, critically important. And it doesn't happen. One of the other units in the UK has got a great system. You come into the room to start the procedure, and then they lock the door. I'm not saying you have to get to that length, but if you think about in your own unit how much traffic there is in and out the room, it's very, very distracting to the individual holding the scope. And if you're training, it's very intrusive into the training. And in the top right, really, you need a safe space somewhere where you can actually do some debriefing. So probably the most critical part of training, interestingly, is not the handling of the scope bit. It's the feedback afterwards, where you sit down and have a conversation and reflect on what went on, and really trying to get the trainee to improve by a little bit of self-reflection and learning from what has gone on. So you need an area, a space really, where you can go and do that. Sitting inside the endoscopy room is fraught with hazard, because people, as soon as the procedure finishes, you're being interrupted and people want to speak to you and talk to you, and you're getting pulled left, right, and center. So you need a safe space. So the environment really has to be ideal. And then the killer one is time. Time applies to lots of things. You need time to have a chat before you start the procedure. You need to have a time to have a chat after the procedure. And actually, you need to be given extra time if you're going to be training, because things tend to slow down. Now, that's not to say you can't be efficient how you use your time. You can train, and we often do, we'll train 2 trainees on the same list. So they do alternate cases. So they can be doing, you can doing parallel tasks sort of thing. So there are ways to make time efficient, but everyone else in the department has to understand that training will take time. And it's something I think that people regard as having not enough of, and that's usually because the planning isn't sufficient. And come to the planning, we need some way of screening and triaging the cases. So the most difficult cases does not arrive on the trainees list. And really what you need to think about in a bit more sophisticated way is, as that trainee progresses, the complexity of the things they're dealing with needs to increase. So maybe more challenging procedures, maybe moving on to polypectomy, and maybe increasing the number of cases that are expected to do within a time frame. So we need to have some system where that works. So you reduce the lists initially, and then you ramp them up to having really normal lists. So I would suggest you, when your trainee is about to become independent, they should be able to run the list, and you should rather be in a supervisory role rather than a training role. And if they're not able to do that, they're probably not ready for independence, irrespective of what numbers they've got. And then finally, the trainers, I'll just mention this briefly. I think if you haven't got effective trainers, you're going to struggle to provide good quality training. And there's a behavior and attitude element to this. They obviously need to be competent with the procedure, and they need to be competent in training. And these are really my final points, really. We cover this a lot, and if you go to the GIEQs website, we've got a whole webinar on this, but this is how you normally acquire a skill. You go from being unconsciously incompetent, you rapidly recognize you can't do the thing you're trying to do, which is conscious incompetence, and then you get training to be consciously competent until you're very good at it in your autopilot, which is the bottom left box. And the problem is, in colonoscopy training, we just seem to leap from top right to bottom left, or we think we're in the bottom left, sometimes we're not. And if I draw this in a different way, this is really normal skills acquisition. And you'll see in this top right box, to develop conscious competence, it depends on the complexity, really, how long it takes to get here. And this step here is all the training you provide. So if people are missing this box out, they're not having effective training. And in colonoscopy training, sadly, this is often the case. And you're given a go, and then suddenly you're left to be independent. And if I can do one thing, I could urge the trainers to understand what they're trying to train before they start training. Otherwise, their own training is going to be difficult.
Thank you very much. So I've been asked to talk about overcoming challenges in colonoscopy intubation. And there are many challenges, but the place, how do I get my next slide? Oh yeah, sorry, how do I go back? So the lecture objectives for this talk are to understand the most efficient equipment setup. So I think that's really important at the beginning. Excuse me. And I'll talk about that a little bit, talking about augmented torque steer technique, which is really important to minimize loop formation, and understanding proactive patient position change. And we know that patient comfort is very much related to avoiding loop formation. So if we think about the efficient equipment setup. So, the first things when you're in the room is to make sure the room is set up for you as the endoscopist. So I'm very short. So I always often have very tall trainees. So I'm always moving the bed height and the screen height. So your screen height should be at eye level. You don't want to be putting additional strain on your neck. You should make sure the bed height is at hip height for the endoscopist. Ensure that your left hand is in a neutral position and not working very hard, lifted up into the air. And actually, when you begin with the patient in the left lateral, you would ideally have your right hand under the trailing scope coming back, because we know we're setting up for the next thing. So in terms of conscious competence, which I think everything that we do in endoscopy, there should be a reason why we're doing what we do. And it's, we should be thinking about why that is. And once we know why that is, we can explain that to our trainees and convince them of the importance of it. So if we move on to augmented talk stare, so at the beginning when we're in the rectum trying to get out, often, it might be that a quarter turn anti-clockwise might be, to the trainee, seem to be the easiest thing to do. But actually, I would suggest that they are using a 3/4 turn clockwise to try and prevent that alpha loop going in the sigmoid colon. And sometimes people need to do it themselves and try and realize that that is going to prevent that loop forming before you can convince them. I think with trainees, often they don't realize quite how much torque is required. And I think the other thing about torque steering is using a finger roll technique rather than a fist grip, because you can't maintain the torque if you have to keep letting go of the scope, because you can only turn this much, whereas if you're rolling it in your fingers, you can keep going and maintain the torque. So dynamic position change. So we use a lot of position change. We're using midazolam and fentanyl or Entonox or nothing in the UK generally. So our patients are able to move. If we're starting the left lateral, we often use water, and that's utilising gravity to weigh down the sigmoid colon, which then reduces the angulation at both the recto-sigmoid junction and the sigmoid descending. So that can be really advantageous. But, if we can't use water, perhaps the bowel preparation isn't good enough, or that doesn't seem to be working. It's always understanding, so what's the next best move in terms of technique? And actually, this is from James East's paper published in 2014. But I think it's understanding that the use of gravity to improve visualization. So right lateral position for the patient to look at the left colon, supine to look at the transverse, which we're then using CO2 to distend to give us good visualization. And then to get round the flexures, we might also want to be thinking about moving. So whether we're proactive or reactive, or maybe a combination of the two. But actually, if you struggle in supine, you should move the patient to left lateral to get round hepatic. But then, and it's really not being afraid to keep moving the patient, because they do need to move a lot down in the cecum, which is often medial. We need the patient to be right lateral to get a good inspection there. So there's many different components to this, and actually, we as trainers should be thinking all the time, and to encourage our trainees to be thinking actively about what they're doing and why, and that will really help with the conscious competence. I think this idea, often people are very keen, they can see the way ahead and they just want to get there, so they kind of rush. But actually, this idea that if we just slow down and be patient and allow the lumen to open, that actually is very helpful to prevent loop formation as well. So really that concludes my presentation.
So I'm going to talk about extubation. We've heard about intubation, and so really focus on this really important part of colonoscopy training. So my objectives for this session is to describe the key manoeuvres that are required for extubation, and then we're going to see a demonstration from the live room on some of these kind of key principles, discuss the timing of extubation in training pathways, and describe the importance of high quality extubation training. So I recall speaking to one of our recently independent endoscopists who to finish their training and asked them what they were kind of concerned about when they started the independent list. And the two things that came up was understandably therapy and coming across that and dealing with that. But they also talked about the list time management and particularly with withdrawal times and being able to kind of withdraw in an effective way. And the main concern was not taking too long to withdraw and slowing the list down. So I think when I heard that, I felt we'd failed as trainers, because I think this is kind of a really integral part of training. But I think a lot of the focus is on the stuff that we've already heard from Becca about the intubation. Certainly a lot of the key performance indicators are very much designed around intubation and not so much around withdrawal. But it's a crucial skill as part of colonoscopy training. So why is it important? So we know that endoscopists with good withdrawal technique find more polyps, and there's good evidence from this, and the kind of seminal Corley paper looking at this showed that endoscopists with a high adenoma detection rate have lower interval cancer rates and lower colorectal cancer related death rates. And in fact, just a 1% increase in adenoma detection rate was associated with a 3% reduction in cancer risk and finding a cancer interval colonoscopy. Crucially, the Kaminsky study that followed 3 years later showed that actually if you improve your adenoma detection rate, there is a corresponding decrease in the interval cancer and death. So if we can improve our trainees' ability to identify adenomas, even by a small percentage, we can have a really significant impact as trainers on patient outcomes. So again, I won't go into the details of that. And of course, you need to be reinserting the scope if it slips back. So looking at all those particular techniques you need for withdrawal, what are the underlying skills that the trainee requires to be able to achieve all those? Well, first of all, I'd say tip control is crucial, use of torque, and really understanding the anatomy to move the patient into the correct position. So if we look at a kind of a training timeline from left when they start to right when they finish, I think the focus at the start is very much around tip control and insertion technique. But fairly shortly after starting, they can start thinking about therapy and they can start thinking about withdrawal techniques. Certainly, we recommend starting therapy when they've got sufficient tip control to be able to do that safely. But if we think about that, starting colonoscopy with training with withdrawal is not ideal, and because they haven't really got the tip control. And if we look at this timeline, I'd recommend starting the simulation training to get the tip control, followed by a demonstration of withdrawal. So there's plenty of opportunity to demonstrate how to withdraw effectively, and then start segmented withdrawal training as we've heard from Becca, and then practice those individual sessions, and then refinement of withdrawal towards the end of training, and then how to manage list time towards the end. As I mentioned, current KPIs focus on intubation, and I think we need to be thinking more about effective withdrawal technique towards the end of training. And I think this is also important because we do see variation in adenoma detection rate. This is data from the post-colonoscopy colorectal cancer data in the UK, and this is looking at the rates of post-colonoscopy colorectal cancer in all the English hospitals, and you can see a significant variation across all of those hospitals. So there are lots of factors that influence that, but I would say withdrawal is a very important factor. So I think there are plenty of opportunities to improve this, improve PCCRC, including local KPI review. I think GIEQs and other kind of education platforms are absolutely crucial to this. So it's fantastic with the opportunity to be able to kind of talk about this today. Lots of research going into optimal withdrawal technique. I think artificial intelligence is going to be the future. It's going to be able to show us what percentage of the mucosa has been visualized. And so we can really get a good understanding of the quality. PCCRC audit ongoing. And I think it's incumbent on training centers and academies to really focus on withdrawal as well as intubation as part of training.
So if we can roll the patient to the right, and in the meantime, when they're doing that, I can inform you that I've asked for some infocol in the wash. We can't do that. So to me, right. And we've also given the patient some Buscopan. So I just want you to see what happens when we roll the patient to the right lateral. You can see why we switch the propofol off in the cecum, and the patient wakes up and can do this themselves. Life would get a lot easier. For those of you who use propofol sedation, I'd encourage you to do this. then we distend. And you see the fluid has left the cecal pole, and guess what? We have a little polyp. Yeah, well, there we go. Which I didn't see, to be honest, before we rolled the patient. It was underwater. Multiple polyps. So there is the lesion near the appendix. There's another one just adjacent to that, and there's a third lesion down here. So that simple maneuver has revealed three polyps. The gentleman appears to have, I'm assuming it's a gentleman, he appears to have a lot of right-sided polyps and slightly less as we come out. And I'm conscious that for the team, it's a difficult procedure. It would be sensible to clear the colon pole. So I could continue to the end, but I think we really need to clear the right colon, I'm afraid.